Welcome to Psych Talk. I'm your host, Dr. Jessica Rabin, a licensed clinical psychologist. If you are a mental health professional, student in the social science field, or just interested in psychology and mental health, this podcast is for you. Although topics discussed on this podcast are similar to therapy, Psych Talk is not a replacement for therapy and is for educational and entertainment purposes only. So let's dive into today's episode. Hey everyone, welcome back to Psych Talk, and thank you so much for joining me for today's episode. Today I have a very special guest with me, Katie May, who is a licensed therapist and Linehan board certified clinician. So Katie, thank you so much for being here today.
Thanks, Jessica. I'm so jazzed to talk about high-risk teens with you, so thanks for having me.
I am super excited as well because this is not a topic I've covered on the podcast yet, which is pretty impressive since we're over 250 episodes in. So I'm so excited to have your knowledge and expertise on the podcast discussing something I know you're so passionate about. But before we jump into that discussion, can you introduce yourself, a little bit about your background, what you do, and anything else you want to share?
Absolutely. As you shared, I am a licensed professional counselor in Pennsylvania. I lead a team of about 20 therapists. We all work with high-risk teens and are trained in comprehensive DBT. And I also created a framework from my time-tested decade plus of working with teens for working with high-risk teens and integrating caregivers that I train other therapists on nationally.
That's awesome. That's awesome. So how did you come to specialize in high-risk teens, and why are you so passionate about this population? Because even just in that brief intro, I can tell how
Mhm.
passionate you are.
I'm so passionate about it. And I hear a lot like, oh, it must be so hard to work with this
Mm.
population. And yes, it is. And I love it. I myself was a teen who struggled, and I felt like it took a long time to get to the right support and the right results for me to feel good about my life. A lot of it
Mhm.
was trial and error and learning, and a lot of therapists and support people along the way. And so there came a point in my life when I decided I wanted to go back to school to be a therapist. And along that journey, I really discovered that I had a knack for connecting with teenagers, for
Mhm.
understanding their experience. And I truly think it was because of my lived experience that I was able to understand conceptually what they go through in a way that maybe some other therapists couldn't. So I just found joy and fulfillment in that
Yeah.
process.
That's awesome. I always say that, as therapists, we don't have to have the same experiences as our clients to help them.
Mhm.
And giving foreshadowing of some DBT skills right there. And I think there is something special about having that lived experience so that you can understand from a different perspective. Like you can understand clinically, but also lived experience wise, even if your lived experience obviously isn't exactly the same.
Absolutely. And I think I bring to the work my lived experience, but also I am the parent of a teen, and I've worked in the
Hmm.
field working with teens for 12 years now. So I really have these three lenses that I'm always orbiting when I'm working with clients and their caregivers to understand how it all fits together and what everyone needs.
Hmm. And I think that's so important. And I'm sure we're going to get into this at some point. But, when you are working with teens, you are also working with parents, caregivers, guardians, whoever the
Mhm.
adult or adults are in their life. So I think it's so important to have that knowledge and broad perspective and lens as a parent, but also your willingness to work with not only the teens, but the parents, because, you know, teens function in a system. You know that probably better than I do as someone with a teen and a clinician for teenagers.
Absolutely. Working with the whole system. I think an understanding that you're only working with a teen client 1 to 3 hours a week, depending on if they're in a group with you or individual, but
Hmm.
they're going home into an environment that really also needs support and structure and to be ready for changes and to learn how to skillfully validate and all of the things.
Yeah. Oh, absolutely. So we've been using this term high risk teen or high risk
Yeah.
teens. And one thing I really like to do on the podcast is define terms so we're all on the same page of what we're talking about. So, what is a high risk teen?
The way that I see a high risk teen, and I use a lot of language to describe this population, I'll say high risk, I'll say self destructive, because I want to broaden the lens from not just suicidal ideation, not
Mhm.
just self-harm, which does tend to be the area where I do the most work. So it's the area that I am the most passionate about, but I'm aware that that's not all encompassing of some of these
Yeah.
other behaviors that serve the same function. So I want to give you an idea of how I look at it. The way that I see it is that um, with a teenager who is biologically sensitive, with a teenager who feels their emotions in very big ways, it often feels like they are on fire with those
Mhm.
emotions. And so when that fire gets so big, it's all consuming, it's so painful, their brain comes up with a strategy to help them escape that pain or to put the fire out. And so these strategies are things like suicidal ideation or behaviors,
Mhm.
self-harm, could be substance use,
Mhm.
could be disordered eating behaviors, running away, lashing out. So there are a lot of different behaviors that I would say put us in a higher risk category or
Mhm.
a higher category for self-destruction. And if I'm really thinking about that word risk, I might look more toward those life-threatening behaviors as the
Mhm.
highest risk category.
Yeah. No, that makes perfect sense because, we think of teenagers. Teenagers are going through a lot of changes, like hormonally in their life,
Mhm.
things like that. So there are, what we would say, quote unquote, typical teenage behaviors, but,
Yeah.
you know, high risk behaviors, things that, like you said, potentially are life threatening or could get them in physical harm or other
Mhm.
types of harm are definitely things that parents, clinicians need to be aware of, which I guess brings me to the second part of that question, because I know
Mhm.
you're an expert in this field. Like, why would traditional like therapeutic approaches often not work with this high risk population that you so beautifully defined for us?
I see a pattern of a lot of therapies focused on the problem behavior. And I'm
Mm,
not saying that I don't focus on changing problematic behaviors, but I
yeah.
really want to shift the mindset and the focus that what adults are often seeing as the problem is a solution for the teen client. Because as I
Hmm.
just described, it's typically a response to some big and overwhelming emotion
Yeah.
and or some need that they have to communicate that they don't have the words for, or they're too dysregulated to put together and advocate for themselves.
Hmm.
And so instead of solely focusing on changing the behavior, changing the problem, talking about the problem, we're doing a lot of assessment to get beneath the problem to understand the true
Hmm.
problem, which is the underlying emotion
Yeah.
driving and contributing to the behavior.
Yeah. No, that makes a lot of sense because I mean, thinking of the lens of like a parent, but also a clinician, like when we are doing our intake or you're asking like the parent, like, why do you bring your teen in today or your child in today? They're like, oh, well, they're being disrespectful, defiant, they're lashing out, they're engaging in self harm. And it's exactly what you just said, all those behaviors that really
Mhm.
are their way of coping with something underneath.
Exactly.
And a lot of time, I don't know your experience, and I don't want to assume, but I know in my experience, a lot of parents are like, I need you to fix, and I hate that word when it comes to like therapy or just talking about people in general, this behavior. I need you to fix their disordered eating or
Mhm.
fix their self harm. I don't want them to self harm anymore. And like, yeah, I mean, I would love for them not to self harm too, but we can't just be like, stop doing it.
Right. Right. I don't like that word fix. And if we're talking about words we don't like, I also don't like the defiant and disrespectful
Hmm.
judgments.
Yep.
But to your point, that need for the teenager to stop engaging in the behavior, the need from the parent to quote unquote fix them really comes from the parent's own fear. They're so
Hmm.
scared. It's hard to see your kid hurting themselves or self-destructing.
Absolutely.
And so I like to hold that yes, I train a lot of therapists on my team and outside of that where we talk about this parent pressure and how it feels like we need to move therapy along because parents want therapy to move along. And I
Hmm.
really try and zoom that out and empathize with this idea that these parents in their everyday lives are seeing a teen struggle and self-destruct, and that hurts and it's painful. And so I need to hold that as I'm managing their expectations.
Hmm. Oh yeah, that absolutely makes sense. So I just asked, like, why do these traditional approaches not often work with high-risk teens? And
Mhm.
so what would you say, like, as therapists, we're two therapists here, are some of the most common traps, if that's the word you want to use, that
Yeah.
therapists fall in when it comes to high-risk teens? And then the second part of that is like, how can we as therapists avoid falling into
Mhm.
those traps or patterns?
I have two traps for you.
Okay.
The first one is the belief that you need to build a ton of rapport before a client can feel safe talking to you about these high risk behaviors. I
Okay.
fear that this myth that there needs to be a lot of rapport can get in the way of actually doing the accurate assessment and moving
Hmm.
towards keeping that client safer sooner because they know
Hmm.
why they're in therapy. And
Yeah.
the antidote to that is having a structured assessment process that does both at the same time, that allows you to build rapport while you're asking the hard questions. One of the things I use is called the HOPE model. HOPE is an acronym. So we're asking about what's your home life look like? The O is for occupation or school. What do you do with peers? What do you do for enjoyment? So you're asking questions to get to know your client and you're getting them comfortable. They're answering, you're getting details probably from that that gives you more
Hmm.
information about how they get along with people at home, how much social
Hmm.
support they have. But then you're moving into harder questions. And I ask in the very first session about suicidal
Hmm.
ideation, about self-harm, because I don't want to waste time not getting them to safety when they could leave my office and act on an urge again. I want to know right up front what we're
Yeah.
working with and how to help them. So that's my first myth or trap, if you want to call
Hmm.
it that.
Yeah. No, that makes a lot of sense because I think a lot of times, even clinicians are like scared to ask the hard questions. Like, I'm a stranger.
Mhm.
They're not going to open up
Yeah,
to me if I just like go in with, are you thinking about suicide?
right.
But I also ask and assess suicide and self-harm questions at my intake as well. But I, you know, put it in with things like, you know, tell me about your hobbies, interests, things like that, and building up
Hmm.
to that. But like, honestly, until you just said that, I never really thought of that as a trap, but it absolutely makes sense, especially in the context of high risk teens. Because to your point, if you're, I don't know, having a 60-minute, 90-minute intake session and
Yeah,
never assess for suicidality, and then they go home and are feeling suicidal and act like you spent all that time building rapport, but not maybe assessing for the things that are the most important.
right. And it can be both. So
Yeah.
I like to make sure that we're aware that it can be both. Part of the segue from that to the second myth or trap is that I think it has a lot to do with a therapist's comfort level. And so
Hmm.
therapists need to feel comfortable and not stall out trying to, ask those hard questions. The second trap is pushing panic and sending kids to the hospital sooner than is necessary because therapists fear liability. They fear, well, what will
Hmm.
happen if they act on something? Is the client actually going to be safe? When in fact, we have no control over what our clients do outside of the time that we're with them in session. And even though that's the case, it is my job as a therapist to manage my own nervous system so that I
Hmm.
can make the most wise-minded call about what this client needs and not reinforce a cycle of hospitalization. Just because dysregulation shows up, just because urges show up, does not mean that we need to remove all stressors and put a client in a locked unit. It doesn't
Hmm.
always mean that we shouldn't do that, but we need
Yeah.
to have discernment about when that's actually clinically indicated and when it's based on somebody's emotions that are in the room.
Hmm. I love that you brought that up. And I feel like we could probably talk about like psychiatric hospitalization for this whole
Oh, I
episode.
worked in some, yes.
But no, I feel very similarly in the sense of I
Hmm.
think a lot of times because of liability, or especially clinicians that work for some type of practice that has a
Hmm.
policy that maybe they don't have as
Yeah,
much control over, um, they somebody or the client will say like, "Oh, I'm having thoughts of suicide." Maybe they're not formally trained on good assessment or safety planning, which I know we'll get into here in a little bit, and
Mhm.
jump to hospitalization. But going, as you were talking, going back to the first trap of building rapport, a lot of
Mhm.
times inappropriately acutely hospitalizing somebody can break that rapport. So the rapport
Yeah,
that you were spending all that time working towards, then that trust can be broken. Not all the time. And like you said, there are
right.
absolutely times that people do need to be hospitalized. And I have seen and I have heard from or from current clients that had past clinicians that it was like, my therapist just hospitalized me and it was like the most traumatic experience of my life. And I wasn't
Yeah.
able to open up to them
Or
after
if
that.
you exactly, you think about all of the shame or fear or
Mhm.
emotion or hesitation it takes to actually say those words out loud, to actually share it with someone else, and for them to make the decision, maybe unilaterally, that you need to be hospitalized, can be pretty upsetting for clients.
Mhm. Oh, absolutely. And I think that a lot of times when we're thinking about high risk teens too, at least in my practice, I think about, is this different from their baseline or is this different
Mm,
from the average? And I hate the word average, but like, I guess the point I'm trying to make, because like some people are always going to endorse suicidality.
yeah.
Like I have
Hmm.
teens that are chronically suicidal. And so for them, I'm not going to hospitalize if
Right.
every session they're like, yeah, I'm still having my same suicidal thoughts, but they haven't gotten worse. No plan or intent. Okay.
Hmm.
For a teen that's never been suicidal and suddenly
Right.
is suicidal, that's very different. And I think that's part of the nuance of assessment. Is this, different from their baseline? Is this a brief moment of dysregulation that we can utilize coping skills? Or is
Yes.
this a pattern that's escalating and there's an acute crisis that needs to be addressed?
Exactly. Knowing their baseline and basing it off that client versus a rule to hospitalize or not because suicidal ideation shows up, I think is the way to go.
Yeah. And I mean, that can be scary for clinicians as well, especially new
Sure.
clinicians. I mean, I remember being a new clinician and being like, oh gosh, my client endorsed suicidality. Like what do I do? Or having like, how do I know? And so part of it comes with experience as well.
Yeah.
But I think, that's part of building that rapport. Like you said, it doesn't have to be excessive, but getting to know your client and where they are. Is this a high risk behavior that they usually engage in? Is this a new high risk behavior? What is the
Right.
severity, acuity, all that kind of things?
Exactly.
So I know earlier you also said one of the things you do is really collaborate with parents. And
Mhm.
like I said, I think that is so important when it comes to teens. Also challenging because a lot of times teens may not want their parents heavily involved in treatment. And so, a question I have for you is, how can therapists truly collaborate with parents
Mhm.
to help their high risk teen while also simultaneously maintaining that teen's trust and confidentiality? Because this is something I
Mhm.
talk with families and teens about all the time. It's like, well, I'm scared of telling you things because I don't want you to go tell my mom. Or the
Yeah.
parents are like, I want you all to have trust, but I also want to know what's going on in session. So,
Mhm.
what have you found has been really helpful with this collaborative process?
Yeah, I want to hit on all of the points that you just talked about because
Perfect.
they're all the areas that I have seen hesitation when we talk about including parents in the process working with teens. So backing up, 10 years ago when I opened my group practice, we were a teen center. We were not a teen and parent center. And I
Okay.
found myself saying that a lot, like we work with teens, we don't work with parents. And what happened was we would then get these paragraphs long emails from parents telling us, like, here's what happened with Susie this week, or I just wanted you to know, or here's a packet of the background of their history. And so, what I learned from that was that it wasn't that parents were bad or pushing their way in to learn new information. is that they were feeling left out of the
Hmm.
process, and we needed to create a structured process for including caregivers in therapy. And so
Yeah.
that's how I describe it now to the teens that I work with as well. And I use something, I call it assumed consent, where I
Okay.
explain to them how I will include parents in therapy, but I don't necessarily say, hey, can I include your parents? And
Hmm.
I do that for a reason because most of the time teens don't want their parents involved. I'll
Hmm.
say like 80% of the time, sometimes they do. And that makes sense because teens are individuating, because
Yep.
teens are private or they're worried about how their parents will respond. So we share basic confidentiality as all therapists do. And then we say the way that we include parents is we have a parent intake, but it's not about you. We don't share any of the content of what you shared with me. It's about learning your parents' parenting
Hmm.
style, how they were parented, how they
Okay.
regulate their emotions. So we're learning about the parents so that we can learn about the system at home.
Hmm.
And then we also give a heads up on what we do share with parents, which is general themes. Oh, we worked on coping skills this week, right?
Hmm.
Like parent as payer, we give them a little piece of information without sharing anything literal. And the final piece that I think is really important and really changed how we work with parents and maintain that rapport with clients is we have something called the no secrets policy. And we explain this with parent and teen together, where we say, I am teen's therapist. I am here to support the teen. You are a part of their world and you'll be included
Hmm.
in treatment in this way. But I will not hold information about Susie that you share with me that I can't say to them. So don't tell me that you read their diary. Don't tell me that you
Okay.
found weed in their room because I'm going to tell them that you told me so we can work on it in session. And so that tends to maintain this level playing ground where the teen knows that, we're on their side, but we are going to
Hmm.
include parents so everyone can learn new skills. We are going to teach teenager how to talk to parent instead of talking to parent for them, but we're not going to know things about them that they wouldn't want us to know unless they told us themselves.
Hmm. I love so much of everything you said. And now I'm thinking, I'm like, okay, how am I going to change how I um do things? But I love the no secrets because that has definitely happened to me where like parents
Hmm.
will send me an email and be like, hey, I want you to talk about this, but don't tell
Yeah.
them that I told you. And I'm like, how am I supposed to bring up this thing that they haven't told me
Hmm.
randomly? Like,
Yeah.
so tell me about this thing you wrote in your diary. Like, clearly
What'd you write in your
I was
diary
not
this
read. Yeah,
week?
like yeah,
Random, but
exactly. Yeah, like you've never mentioned you had a diary, but like anything important you wrote in it this week. So I love that no secrets policy, and it sounds like
Mhm.
from everything you were describing, it's a way to keep everybody involved, but also have their own autonomy. Because I even heard that with the
Yes.
parents. It's like you're not just asking parents questions about their teen. Okay, why are you bringing your
Right.
teen here? It's like, hey, let me learn about you as well, which I would
Yes.
imagine makes the parent feel heard and seen.
Yes. Exactly. Because everything is transactional in a family. The way that a teenager expresses their emotions is going to be received a certain way by parents. They're going to respond. And so we talk a lot about this like cycle of escalation that
Hmm.
happens. I yell at you, you yell at me, we keep yelling, someone punches a wall, then someone's hospitalized, right? So we need
Yeah.
to break those cycles. And for that to happen, both sides need to learn new skills and new ways of communicating.
Hmm. And I love that you just brought up skills because I know a few moments ago you talked about how you'll do general themes. And like today we worked on coping. And
Hmm.
that's one way I will sometimes involve parents as well. I'll be working with my teen and be like, hey, we really worked on this uh, coping skill that you said you're going to practice at home. I think this would be a helpful point. And I always give my teens like option, like, yeah, I'll bring mom, dad, grandma, whoever it is in,
Yeah.
or like, no, not today. Of this would be helpful for your parent to learn as well. And maybe like you could
Hmm.
teach them the skill or they can help reinforce. And I found if it's more collaborative that way and like
Hmm.
the teen has autonomy, like, oh yeah, like actually mom could probably benefit from this skill as well. It's less about like, I don't know, conflict or, well, they said this or they want to do this. It's more like, hey, I learned this thing. We're
Right.
inviting you in so you can learn it
Hmm.
too and maybe reinforce this. Cause like you said, we're with the teen 1 3 hours a week
Right.
most, unless you're in maybe like a more intensive
Like a
like
higher level of care.
IOP,
Yeah.
PHP. And so the parents and guardians are the people that are around them more. And I have found, especially if it's a safe relationship,
Hmm.
that can be very helpful for reinforcing. And then it also helps inadvertently the parents regulate themselves because they're like,
Yeah,
oh, I'm having to, remind my teen of this skill or they learned the skill. Let me practice it as well so I can co-regulate with my teen.
exactly. I love that parents can learn skills on their own. So we have a parent skills group at my center.
Nice.
And I love bringing parents in and having teen teach the skill to them as well. I think both are really helpful strategies. I also think it's important just to name that there are some outliers for when we wouldn't bring parents into
Mm-hmm.
session. Some of those are like, if a teen has an identity that's not affirmed or supported by parents, and it's not going to be helpful or healing.
Mm-hmm.
So I do always like to inject that little bit of nuance that we want to use our clinical judgment. So most times it's helpful, but not forcing it when it would be harmful is important to
Mm-hmm.
note too.
Yeah. Oh, thank you so much for highlighting that because I can definitely think of times that I've worked with teens that I literally met the parent for intake. And
And
that
that was
was
it.
about it. And I don't know what age of consent is in Pennsylvania, but in South Carolina, at 16, teens can consent to their own mental health treatment. So if they're 16, 17,
Yeah.
they don't need a parent or guardian to come with them. Obviously, in an ideal world, I would have the people they're living with also
Hmm.
be somewhat involved to whatever level is appropriate. But there's definitely been times it would have been more
Yeah,
harmful than helpful. So thank you for highlighting that.
for sure.
So a little bit ago, you mentioned the hope model that
Yes.
you came up with. And I could be misremembering this, so tell me if I'm wrong on this, but I feel like you have a few frameworks, models that you either have
Hmm.
developed or used. Can you talk about some of those models? Obviously, you mentioned the hope model. If there's other things you want to talk about with that are effective in helping high-risk teens in working with high-risk teens.
Yeah, so I have a lot of structured tools that I use in working with teens. One of my favorites is what I call the experiential behavior chain or the bottom-up behavior chain. So I am a DBT therapist, and so this my model is based on DBT, but one of the things that I found missing is that it is very cognitive, it is very
Mhm.
behavioral, but in terms of activating what we're feeling in our body, being able to move into activation and not just narration of what
Mhm.
happened in the week or what happened between the time that you were triggered and the time that you acted on that self-harm urge. Going through that process, which is a typical behavior chain in
Yeah.
DBT, is very narrated. It's very
Mhm.
cognitive. I'm telling you what happened. And I find that when we stay in that place of narration, it's similar to when I used to work in a partial hospital and we would build safety plans and they'd be like, I'll call a friend, I'll pet my dog, I'll listen to music. And it's like they're checking off a list,
Mhm.
but they're not actually making that change in their
Yeah.
life. And so this is where the experiential behavior chain came from, that it is going through that process of what happened from the time you were triggered to what happened when you acted on your urge and what happened after that, but it's
Mhm.
putting them in the scene. So I'm asking them to describe in the present tense, as if we're watching a movie together, what happened. So they might
Okay.
say, I'm walking in the front door. I notice that my chest is getting tight because I know my mom is about to yell, did I do my homework? Or hurry up, I have to go to dance class. So I'm walking up the stairs and I'm picturing the tool in my mind. So even as I'm making this up as I go along and I can feel the emotions. And so what we're able to do in this process is have them freeze frame that moment right before they acted on the urge. And if you remember, we talked about behaviors come from that overwhelming
Mhm.
emotion, we're able to get to that root more quickly because they're feeling it. And so once that
Yeah.
happens, we're able to help them rewrite and repattern those behaviors because essentially they've opened that file in their brain. It's a little
Mhm.
bit of memory reconsolidation, a little bit of that
Yeah.
bottom up activation that allows them to make changes at the body based level and not just
Mhm.
talk about those changes.
Mhm. That makes a lot of sense. And once again, I'm like taking notes. I'm like, oh, okay, let me add this because it is like to your point, it is very cognitive, and at least in my experience, and you can tell me if your
Hmm.
experience is different, when I've done behavior chains or like just even like let's walk through this argument with mom, what happened? A lot of times I get like, I don't really remember what happened, but
Hmm.
somebody said this, and it's very like detached from
Yes.
the emotions. And it can be like, we could talk about, well, what could you do different? Well, I could not like flick her off next time. I
Right.
could just walk away. But it's very like, yeah, cognitive, not emotional.
Hmm.
And like, that's great. Okay, you identified an alternate pattern.
Right.
Are you going to do it
Right.
the next time? Or when you're in that dysregulated state, are you going to go back to maybe those high risk behaviors or those behaviors that are not going to diffuse the situation, but rather escalate it?
Exactly. The other thing I like a lot about it, and I love a good behavior change, so this is not
Mhm.
against the
Yeah.
typical way of doing it, but it is very therapist led. Like it's very, I'm taking my notes or I'm up at the whiteboard.
Hmm.
And there's nothing wrong with that, but there is something to be said for empowering the teen to tell the story and us following them, almost like following the
Hmm.
tail of it rather than leading and having them prompt dependent on what we're asking them.
Hmm. No, that makes a lot of sense. I would imagine that also elicits more reflection. I'm
Yeah,
just coming up with that like on the spot rather than, and I know some people definitely need prompting initially.
sure.
But I would imagine like if it's very teen led and we're just
Hmm.
following it elicits more need for self-reflection or like pause and be like, okay, what was I like, okay, I did walk in the
Right,
door. What happened? Was I already irritable? Was I feeling fine? And then I felt anxious versus us being like, so how did you feel
right.
when that happened? Which once
Exactly.
again, nothing wrong with that, just different.
Different for sure.
Yeah. Okay. Any other like frameworks or models that you use that you have found really helpful or effective that you would like to share?
Yeah, so I like thinking about when going back to this idea of high risk.
Hmm.
We talked about new therapists who are scared to make the judgment call. And
Hmm.
I think that makes sense because
Yeah.
they don't want to be the decision maker. And so I think about the pack framework. In my head, it's like, do I need to pack for the hospital or can I stay home? And it's just a quick way of remembering some of these details. So the P is protective factors. Are there enough reasons that this teen wants to stay in their lives that we can maybe make the decision for them to stay at home? We want to think about access to means. So the A is access to means. Can the family remove them? Do they have
Hmm.
immediate access? These are all safety risk questions that we would be asking, but just a helpful way to think about it. The C is for
Hmm.
can the family keep them safe? I find that with teenagers, this is one of the big questions to ask when we're
Yeah.
considering even delaying hospitalization. Because for me, that's a win too. If I can say, like, typically when you're having this intense emotion or urge, you're driving from the session to the hospital, can we delay it and check in 24 hours instead?
Hmm.
And so, can the family keep them safe? Can they monitor them? Can they sit with them and watch The Office? I find that the older the teen is, it's also more difficult to monitor. Like a 12-year-old
Hmm.
is easier to monitor than an 18-year-old because they have more
Absolutely.
independence. So, we're
Yeah.
looking at those nuances. And then the K is can you keep your emotions in check? And I always go back to that as a therapist is can you stay regulated enough to make the decision that is based on that data that you just assessed rather than your fear or your anxiety or your spiraling what if thoughts.
Hmm. I love that so much. And I was just writing it down and I want to highlight what you already highlighted.
Mhm.
Hi, is that how you say that? No, I'm like, it's not
We're double
highlight.
highlighting.
No,
Yeah, highlighted.
yeah, highlighting. With the can the family keep them safe? Because
Mhm.
that's something I have that honestly has been a deciding factor before. And it sounds like approach things very similar to you. Like, I want
Mhm.
to avoid hospitalization if I can. And there's been times like maybe I'm like, we talked about protective factors, but the teen isn't really sure. And parents are like,
Mhm.
no, we got this. Like, we will remove the means. I will sleep in their room. And like, once again, going back to the nuance, these are usually teens that have very positive relations with their parents feel
Yeah.
like their parent is a safe person. There have been other times that the teen's like, I think I can keep myself safe. And the parent's like, I don't think I can. And I
Yeah.
think that's also helpful information for clinicians because,
Mhm.
like we keep saying, teens exist in a system.
Yep.
And, you know, if the system can't keep them safe and the team is
Yeah.
already maybe fragile, I don't know if that's the right word. I can't think of a better word right now, but like, kind of teetering on, high risk
Vulnerable.
behaviors.
Yeah.
Yeah. Um, the system needs to be able to support and keep them safe. And if they can't, as clinicians, we need to take that information in as well.
And what you did there was so beautiful of looking at all of the variables to make the decision based on the data that was in front of you.
Yeah. And I also like the reminder of keeping our emotions in check because you said something at the very beginning and I can't even remember exactly how you worded it. But, sometimes as clinicians, like we act on, our emotions, our
Mhm.
impulse. And, the reality is like teens that have high risk behaviors or people in general, they may harm themselves. They may
Mhm.
attempt. And at the end of the day, if we do everything we can
Mhm.
to assess things like that, sometimes things still happen. And I think that's important for us as clinicians to remember because if we're only leading by emotions, we're probably not making the best informed or most holistically informed decision because
Yeah.
risk is going to be there, especially when working with a high risk population. I hope that all made sense. I feel like I had like five different thoughts
No, it makes
going to
sense.
you.
And I think it puts therapists in a precarious position when exactly what you're saying, they're leading with fear or they're leading with what could happen because I see the other side of that. Again, high risk center. Like we see high risk
Hmm.
behaviors all the time. And so I see therapists go down this spiral of what did I miss? What could I have done
Hmm.
differently? How could I have prevented this? And the truth is you couldn't because
Yeah.
everyone has autonomy and that's just where they were in their treatment or where they were that day. So I think we need to really detach ourselves from, as therapists, from the behaviors that our clients engage in and just, follow the treatment that we're
Hmm.
providing them and do the best we can. But that's all we can do.
Yeah, absolutely. So that leads me to safety planning
Mhm.
because, we've talked about hospitalization is not always the answer. We've talked about, especially early clinicians, a lot of time don't feel comfortable. In my experience, too, I feel like a
Mhm.
lot of clinicians aren't trained to do comprehensive safety
Yeah.
plans well, and no fault of the clinician. Like if you're not trained to do them, or I'm going to mention this, but then I'm going to stop myself from going on a tangent about like suicide contracts, and things like that. Yep, you're
We
shaking your
won't
head.
tangent.
Yeah, we won't tangent. But what are some effective ways to
Mhm.
safety plan with high risk teens?
Yes. I developed something called the Teen Support Person Safety Plan, and it's a
Okay.
tiered safety plan. And this does not replace those typical, like, who do I call? What do I
Hmm.
do? We still want to have that, so we have that plan in place. But this Teen Support Person Safety Plan is 0 to 3. You could
Okay.
probably also make it 0 to 5, whatever you're choosing. And we're looking at each level, how do I feel inside?
Hmm.
What would people see outside?
Okay.
How can I cope when I'm alone?
Hmm.
What can a parent or support person do when they see me at this level?
Okay.
It also can include code words for if I don't feel comfortable saying I'm feeling really depressed or I'm having suicidal urges, then maybe there's a code word at level 3 that they can say, or, so parents know. But the point of this is that risk is not a pass fail. It's not
Hmm.
I'm going to do it or I'm not. There are levels, there is escalation. We want to know what the escalation looks like. But I think one of the most important pieces of this is what would other people see when I'm at this level? Because I work with, I want to say 80% neurodivergent teens where they
Hmm.
either don't know how they feel on the inside or when they get really dysregulated, they lose the ability to speak or to advocate for themselves. And
Yeah.
so we want to have this way for others to be able to clock, oh, Jessica's at a level 2. I'm noticing her cover her head with her blanket. She's really irritable. She's snapping at me. So I know that instead of rushing in and asking a bunch of questions about what you need from me, that I'm going to grab a drink from the fridge, put it next to them, and say, I'm sitting next to you when you're ready to talk to me. So it
Mm,
gives each person in the system a plan for how to respond, because that is part of what escalates to crisis, is how the
yeah,
parents respond to the escalating crisis.
yeah. I love that because, I couldn't even tell you how many safety plans I've done in my lifetime. And obviously will include parents or
Mhm.
guardians a lot of the time. But I do think like reflecting just briefly in my mind, um, we talk about warning signs, things like
Mhm.
that. And like even maybe like, okay, this is what they need, but having the tiered approach because I mean, I'm sure you and I can relate to this. What we need in certain moments is not what we need in other
Yep.
moments as well. And I have found a lot of times, like you brought up earlier, parents do not like seeing their children in distress. It
Yeah.
is distressing to them. And so a lot of times people jump to fixing. Well, what's
Hmm.
going on? What can I do? What can I help? Try this, try this, try this. And for somebody that maybe is already overstimulated, shutting down, not talking, like you said, that's just going to make it a lot worse. And maybe
Yep.
instead of a 2, they're now a level 3, or I don't know which way your level system goes,
Yeah.
but like higher
Higher
level.
is
Yep.
worse. Yep.
Yeah, higher is worse. And then that's instead of going the direction we want to with good
Right.
intention, like
Right.
the adult in their life is trying to help, but instead of bringing the 2 down to a 1, the 2 was brought up to a 3
They're bringing it
because
up.
they're like, "What can I do to help? Oh, do you want this? Do you want this? Do you want this?" And the overwhelmed team is already like, I can't even speak right now.
Right.
And now you're
Right.
frustrating me even
Or
more.
the other thing that happens is they lose trust that they can go to parents with these concerns because
Hmm.
parents are so dysregulated in their own right, again, with good
Yeah.
reason. But the nuance in facial expression and tone, the crushed face that happens, they think, I'm hurting my parent. They can't handle this. I'll keep it to myself. I'll stuff it down. And we know that doesn't work.
Yeah. Oh, absolutely. Absolutely. So you actually beautifully foreshadowed this earlier, and I was like, do I jump this in now or not? But
Oh, what did I
describing when
do?
I asked about like how you describe high risk teen, you said,
Yeah.
it's like they're on fire, and you wrote a
Hmm.
book. You're on fire. It's fine. Effective strategies for parenting teens with self-destructive behaviors. And as we've been talking about parenting and high risk
Hmm.
teens, can you share just a little bit about your book? What inspired you to write it? Who it's for? Anything you want to
Yeah.
share about it?
I actually wrote two books, so I'll share
Okay.
about both of them.
Perfect.
My first book, the one that's already out, it's called You're on Fire, It's Fine, and it is a parenting book. It came to fruition because it was the gap in what parents at my center needed to know to be effective with their teens. So that is the program that we run at our center. I really felt
Nice.
strongly that therapists and parents everywhere needed that structure if they were working with teens. And really, the starting point for thinking about that book is when my dad said to me, there was no parenting book to parent a teen like you. And so I thought, challenge accepted. Now I will write that book because I was a teen who self-harmed, and I think
Hmm.
other parents and teens and therapists need to know how to get
How
through
to,
that in a way that's skillful. And so I built on that work for my second book, which comes out in July. It's Teen DBT in Practice. It's the comprehensive guide to treating teens with high risk behaviors. And it's the clinician side of things. It has a lot of
hmm
the tools that we talked about today because I felt like therapists needed their own guide. So now
hmm
we have the parent and the therapist side, and
Yeah.
we can come at it from both sides.
I love that so much. And congratulations on your second book
Thanks.
coming out this year. I know writing a book is not an easy feat. So, and that's awesome that the book is really the program you implement at your center because, obviously you've built this great center. I think you said you have over 20 clinicians in
Two
your,
locations, about
yeah,
20 clinicians, give or take on any month.
and and yeah, any month. And, I am sure there are parents who don't live near you
Yeah,
and things like that that can't access that. So having a book to kind of help guide parents can be extremely helpful.
that's my hope.
Well, Katie, I have love this discussion. I have learned so much from you. I've been taking notes. I'm like, okay, this is how I'm going to change what I do
I
or
love
how I
that.
approach things. But as we're wrapping up, is there anything I
Mhm.
haven't asked you about that you would like to touch on, revisit, share, etc.? Before then, obviously, I'll ask you to share all your contact information and things like that.
Yeah, I really think driving home this idea that all teen behavior serves a function, and
Hmm.
when we can have the right structure, when we can use the right strategies to decode that behavior, we can really change the outcomes when we're working with teens and parents.
Hmm. I love that. I love that. Well, the last question I ask all my guests is where can people connect with you? Where can people purchase your book that's already out? I don't know if your other one's out for pre-order yet or anything, but where can they find you? All the places.
Yeah, best place to find me is my website, katiekmay.com. It has all my projects and programs there. You can also find me on Instagram, same at katiekmay. And my book is available anywhere you buy books online. So you can find it on Amazon or Barnes& and Noble online. It's You're on Fire, It's Fine. Second one will be out in July, so stay tuned for that.
Awesome. And I will put links to your website, Instagram, and book in the show notes of this episode. But
Awesome.
Katie, thank you so much for coming on, having this discussion. Like I already said, I learned so much from you. I can tell how passionate you are about this population and working with high risk teens. And I know you have given listeners, whether they're parents or clinicians, some really good, useful skills that they can take away. So I just appreciate your time and your knowledge, and thank you so much for coming on.
Thank you. I appreciate you.
And thank you, the listeners, for joining for today's episode of Psych Talk, and I will catch you in the next episode. Bye. Thank you for listening to today's episode of Psych Talk. Please rate, review, and subscribe to the show. And if you enjoyed today's episode, please share it with a friend. Don't forget to follow me on all socials at Jessica Lee, PhD, and the podcast at Psych Talk Podcast on Instagram.